Now, when we do this, we have to consider, just like we would with our other infiltrations, where the innervation is coming from. The bulk of the innervation is going to be coming from the greater palatine nerve that's exiting the foramen at the posterior of the palate, running up to support the tissues in this region. So what that means is the bulk of our anesthetic should be just slightly distal to that first premolar to ensure that we get a good blockade of those fibers. Now, the technique itself basically involves using a cotton swab, and we're just going to do today just the topical anesthetic and the syringe, and that's it. No fancy tools or aftermarket products. If you want to look at those, you can look them up in your own time. This here is a tried and true way to do it, and the way that I do it on a daily basis. So what we're going to do is we're going to find that position that I talked about, which is just distal to that first premolar. We're going to use a cotton swab with some topical on it, and we're going to push on that area hard enough to blanch those tissues. So we are taking advantage of the gate control theory of pain, which we'll talk about in another video. Pressure anesthesia, in other words, in addition to our topical anesthetic. You're going to do this for a minimum of 1 minute, and then what you're going to do, and I'm going to have to let go of this to grab my syringe, but normally you're going to be holding that swab in your other hand. You're going to maintain the pressure that you have, and your assistant is going to place the saliva ejector just distal to the injection site to soak up any of the anesthetic that happens to leave the tissues. This is tightly bound tissue. Sometimes you'll get some spilling out as you're injecting. So you want to approach this with your bevel of your needle facing the bone, and you want to have your cotton swab, like I said, still in place here. You are going to enter just mesial to where your cotton swab would be, so that you're in the area of tissues that are blanched. And as you're entering, you're going to bow your needle and you're going to apply pressure, and as you lift up, the tip of that bevel is just barely going to penetrate those tissues. When it does, you can deposit a drop of anesthetic and give it a second or two, and then begin to slowly advance, again leaving a couple drops of anesthetic as you're advancing, and you're going to contact bone. When you contact bone, you want to aspirate, and if you get a negative aspiration, you can go ahead and deposit your anesthetic.